we can get started. People will obviously be coming in, I'm sure, in the next few minutes as well. Hello, everybody, and thank you for joining us in the this evening as we begin our second of four events for our series of Let's Talk Fox Valley Caring Conversations, honoring National Healthcare Decisions Day. If you were not here yesterday, my name is Josh Nelson. I'm the outreach coordinator for the Fox Valley Advanced Care Planning Partnership through and we sponsor Let's Talk Fox Valley, which is a community movement to improve end-of-life care and encourage advanced care planning conversations and planning. So National Healthcare Decisions Day, what is it? Well, for the past decade, it has been on April 16th, traditionally the day after tax day, as there's nothing more certain in life than death and taxes. As Benjamin Franklin once said, it is a day that it's a nationwide initiative to encourage people of all ages and backgrounds to share their personal wishes regarding their future medical care, and for healthcare teams and facilities to respect those wishes, whatever they may be. So without further ado, I'll be introducing our speaker that we have on today. We have Tim Adams, or excuse me, Jesus, Timothy Jessick of Theta Care. He's the medical director of post-acute care at Theta Care. Tim spent over a decade at Aurora Healthcare as a palliative medicine physician before heading to Theta Care this past January as medical director, post-acute care, including senior services, skilled nursing facilities, assisted living, home care, DME, palliative care, and hospice. Tim is also the chair and co-founder of the Palliative Care Network of Wisconsin, mypcnow.org, which was formed in January of 2015 as a network of interdisciplinary clinicians, organizations, and others to educate, advocate, and help improve the healthcare delivery system to best meet the needs of patients and their families. After more than 20 years of practicing medicine, he continues to lead in compassionate and a caring manner while listening, understanding, and honoring his patients' wishes. He is also, as of this past January, a member of the Fox Valley Advanced Care Planning Partnership. And so without further ado, I'd like to introduce Tim. Tim, the floor is yours.
Well, thank you, Josh. And thank you all for attending today. With that intro, I have to thank my mom. So she clearly must have wrote that. So that's awesome. I'm hoping everyone had a chance to watch Ben Adams' presentation yesterday. He's an elder law attorney. He's fantastic. Usually when a physician follows an attorney, that's not a good thing. But in this case, it's wonderful because Ben is so good at what he does, and elder law attorneys can be so helpful. So please check out his presentation if you haven't. As Josh mentioned, I'm a palliative medicine doc. I like to refer to myself as a recovering family physician. So I kind of wore that hat for many years. And a lot of you may know palliative medicine. Palliative medicine is really a newer subspecialty. What we do is we see folks and we take care of patients and their families who have serious chronic or life-limiting illnesses. And I think we do work in the hospital, we do work in the clinic, but I think our role really has increased over the last decade or two. Well, why is that? What is it that we do that other folks don't do? Well, our job really is to have conversations with folks. We're not psychiatrists, but we're supposed to have conversations with patients and families to meet them where they are, to really understand what their goals, what their wishes are, and then figure out from there what treatments make sense for them. Some would say that we're a communication specialist. That's our expertise. That's our tool. That's what we do for folks. If you ask my wife, she probably would say I'm not quite an expert at the conversation piece, but that's for another day. Part of the reason why we've become even more important, at least in healthcare over the last decade or two, is that in the past, the old-fashioned primary care clinicians used to do all this. They used to know you as a patient. They knew your family. They knew your family unit. They knew what was important to you, and then could make decisions with you that would make sense. The problem now is healthcare is very siloed. You might see your primary care doc in the clinic, but then if you get sick and have to go to the emergency department, you have to see a different doc in the emergency department. Heaven forbid you get admitted to the hospital, you got to see a hospitalist who takes care of you, but you don't know them from Adam. Then if you have to go to a nursing facility or post-acute facility of some sort, see another senior care service provider of some sort. And then heaven forbid you end up going on to hospice, it's another provider. So because healthcare is so siloed, no one really knows you. They don't know your wishes. They don't know your goals, what's important. So that's why it's so important to have palliative medicine to help through that. But it's also really, really important. And part of the reason for being here today is that it really behooves all you. It's really important for you all to have advanced care planning with a trained facilitator, get advanced directives done, and really start these conversations early. Start these conversations early with trained facilitators, with your clinician, with family members, to let them know what you want and don't want. So this weekend in National Healthcare Decision Day is just another reminder how important all this really is for folks. So as I mentioned, communication really is a skill. It's something that you have to be taught and then practice over time. And as mentioned, some folks do this well, some clinicians do this well, some not so much. And that's not a criticism. It's just that if you haven't been trained how to talk with a patient, how to meet them where they are, it's a really difficult thing to do. So I say that with all due respect to my physician, APC, even nursing colleagues, because if you haven't had this training, how do you find those words to use? How do you really meet patients and families where they are? So I say with the utmost respect that learning this skill is important, but not a lot of clinicians have had this in the past. So that's part of the reason why it's really, really important for you all to have these conversations, have them early, get some of these decisions documented for you. So what is, from a physician's perspective and a palliative physician perspective, who sees a lot of folks at the end of life, what do these conversations mean and what do they mean for us as clinicians? So, being able to talk to a trained facilitator or your clinician about what's important to you, what your values are, what really matters to you, but also discuss your understanding of your disease process. What is my prognosis with cancer? What does it mean that I have moderate COPD? And what is it going to mean for my health in the future? What kind of care should I have and not have? Those type of discussions and questions are really, really important. And for you to do that early, not only these, what matters most to you, but picking someone you trust to make decisions for you if at some point you're confused or sick or ill. Super, super important to find someone that you trust that can follow your wishes and honor your wishes. So really, by having these conversations early, doing really good advanced care planning, that really can be one of the best gifts you can ever do for your family. Too often I've been in the ICU in a family room talking to a poor family of a patient that's not doing well. It's such a tough conversation to have anyway, with patients, with the family members. But if we don't know what a patient wants, if we don't know what really matters to them because it's never been discussed, no one ever really brought it up, it makes that life and death and what treatments make sense, don't make sense discussion so much more difficult for you all as family members, friends, loved ones. Very complicated for clinicians that just don't know what to do. I don't know what Bob would have wanted in this situation. Should we intubate, not intubate? Should we do surgery, not do surgery? So again, having these conversations, having them early, having them often, again, can be one of the best gifts you can provide for your family. Again, these discussions are tough, but if your spouse knows that, boy, you really wouldn't want to be on a breathing machine or a feeding tube, no way. Grandpa Joe had a feeding tube, and I know my spouse would never want something like that. It's tough having those discussions, but at least for sure what your loved one would want and not want. So part of advanced care planning and completing advanced directives is really about empowering yourself. It's really about advocating for yourself and for your loved ones. But you have to be prepared. You have to ask questions. The old-time Marcus Welby doc, who knew everything about you and made the decisions for you because they know what's best, that's not the case anymore. And it's no longer the case, well, doc said so therefore we have to do it. These are different times. So you really do need to empower yourself. You really need to speak up for yourself with clinicians like myself and others and say, I need more information, doc, about what's going on. You told me I have class 4 heart failure. What does that mean? How long can I live with this? Give me a best case scenario, worst case scenario. What does this mean? I need more information before I can make decisions about open heart surgery and procedures. Ask those questions. That's perfectly fine. And I'd strongly encourage you to ask those questions, right? You need those answers. And we need to have those discussions with clinicians. Should your doc, should your APC, should your nurse ask these for you? Yeah, they should. But again, sometimes they can't. Sometimes they don't know any better. Sometimes they don't know what to ask. If they haven't had training to meet you where you are, to have these discussions, it can be difficult for them. But you deserve still to have some of those answers. It will be helpful for you and your family to really sit down and have these discussions. So please empower yourself, advocate for yourself, have these discussions, ask these hard questions of the clinicians, right? And then once you come up with a plan, once you figure out what kind of treatment you want and don't want, make sure it gets documented. Make sure you can document it. You have a goals of care document done. You can document what you want and don't want. Make sure you get that advance directive done that really clearly talks about limits. Boy, if I have to go to the hospital, that's fine. But heaven forbid my heart stops and I die. Don't you dare try to bring me back from the dead. That happened to grandma. I don't want that stuff. Put it in paper, put it in writing, and then talk to your family, your loved ones about what you want and don't want. So what kind of things do you need to talk about with your family, and questions need to be asked? Again, prognosis. How much time do I have? What does my disease process look like? Talk to clinicians with your family. What matters to you? Boy, based on my faith, I need to have a priest there at the end of life. I want to make sure that somebody like that is there. Based on my preferences, I do feel like I need a feeding tube. That's something that's really important to me, that I have food and water through a feeding tube. Let clinicians, families know that. These things are really important to me. This type of treatment is important to me. But also let them know when there's limits. Boy, I want you to do everything you can for me up until the point I can't talk to my family anymore. If I can't have an intelligent conversation, if I can't gripe about the brewers and having errors like they have had in the past, then life's not worth living to me. Those discussions are really, really important. Really talking about your values is important for us as clinicians, as the healthcare team, but also for your families and for your loved ones. So I want to make sure we have plenty of time for questions from folks. But so what are these? How does this different conversation pattern look like? And I might say that the old-fashioned way of having discussions and talking with or at patients is what I'd call more of a physician-centered approach, right? And it might look or sound like this. So let's say we have a 90-year-old woman who's living independently at a facility. Unfortunately, she falls and hits her head, has a huge brain bleed, and goes to the hospital. She's being evaluated in the emergency department, and this woman's granddaughter comes in. The granddaughter sits down and talks to the emergency room doctor. A physician-centered approach, or kind of the old-fashioned way of having a conversation, might look like this. So the doc comes in and talks to the daughter. Hi, Tina. I just saw your grandmother. I know you're here because of this fall and what happened. I'm so sorry to tell you that. Grandma did fall and hit her head. She has some bleeding in her brain going on. It doesn't look really good. I'm really concerned about her as a physician. What I think we should do next is I think we should probably stick a tube down her throat so we can breathe for her, just in case she doesn't breathe on her own. And because of the bleeding that's going on in the brain, I think probably what we should do is transfer to a bigger hospital where they have neurosurgeons. They can go ahead and they can do a burr hole in their head, drain the blood out, watch her in the neurointensive care unit and see how she does from there. How does that sound? Is that bad medicine? No, not really. This doctor potentially just saved this woman's life. Is this what the patient would have wanted? We don't know. He didn't really ask. He didn't really talk to the granddaughter. He didn't really look for documents to express what the patient may have wanted or not wanted. Is this the right thing to do for the patient? Maybe, maybe not. So what does more patient or family-centered approach look like, right? How would that go? So same scenario. Doc comes in and talks to the granddaughter. Hey, I think you already heard, grandma fell and hit her head. She has this big brain bleed. It doesn't look really good. Looks pretty bad. Looks pretty critical and serious. I'm so sorry to share this news with you. What do you think she would have wanted in a critical situation like this? She's stable. We don't have to do anything right now. Have you talked to her in the past about what she'd want if something serious like this happened? Would she want to go to a different hospital? Would she want really aggressive care? What has she said in the past about this? Right? Different approach. This is where, with good advanced care planning ahead of time, good discussions with the granddaughter, who is now the power of attorney, this is the point where the granddaughter would say, well, this is so sudden and so terrible, and I can't believe this happened to grandma. But yeah, we've had this discussion multiple times. I'm her official power of attorney. We discussed this way back when. And she was very clear that as long as she could be independent, live at her facility, still garden and watch sports and things like that, and talk to me as a member of the family, she wanted to kind of keep moving forward, keep doing things. But you're telling me this is pretty serious and she may not regain her consciousness. She may not give independence. I know for a fact, because we've had these discussions, that she would not want to be intubated. She would not want to be resuscitated. And boy, she would not want brain surgery done. She lived a really good life. She knows she's going to go to see God at some point. She would not want that type of care. What other options do we have? Right? Different approach, different response, because of good advanced care planning, good advanced directives done ahead of time. The response might have been a little bit different. The granddaughter might have said, I've talked to grandma about it. It has been a long time. I know she has advanced directives. She would not want to be intubated or have anything sudden like that. She would not want surgery. But boy, this is so sudden. I don't know what else she would want us to do. Would it be okay if we just watched her in the hospital for a couple of days to see if she wakes up and see she does better? But I don't want to transfer someplace else. I don't want her to have surgery or anything. Great response. To which the doc can say, of course we can watch her. We know what the limits are. I'm glad that she's discussed this with you in the past, that she doesn't want to be super aggressive. Of course we can watch her for a couple of days, and we'll have another conversation, in 24 to 48 hours to see how she does. The other option might be, yeah, I've had some discussions like this with grandma in the past, but I don't know what she'd want. Yeah, I think we should do everything possible, including going to another hospital and have surgery. Again, a lot of different scenarios, a lot of different possibilities, but it all stems on what a patient's wishes are. It all stems from conversations that have occurred in the past, but it also depends on the conversation between the clinician and the patient, or in this case, a family member. Do they really understand how serious this illness is? Do they really understand how bad things are? And what do we think that the patient would have wanted in this circumstance? So again, very, very important to have these conversations with medical staff, and then to share your decisions and some of these scenarios with your loved ones, so they know what you want, what you don't want. You can't prepare for every scenario. Well, if I ever stub my right big toe, I clearly don't want surgery on that toe. No, but kind of broader sense of, living and being alive is what matters most to me. Keep me alive no matter what. Or I value spending time with family and being independent. And boy, I never want to go to a nursing facility, so don't ever send me there. This is the type of care I want. Having these conversations earlier are super, super important. So with that, I think I'm going to pause just to make sure we have plenty of time for questions from folks.
Yeah, I'll step in too. So anyone that does have questions for Tim, if you you can either unmute yourself and you can say it aloud with your name as well. Otherwise, if you want to direct message us or put it in the chat, that works just fine. And then we can hand it back to Tim as well. Here's one, Tim. How do attorneys partner with healthcare providers to make sure completed advanced care planning documents are filled in the provider EMRs?
It's a great question, Josh. Again, we were so blessed to have Ben Adams speak yesterday, and even though we might joke about attorneys and physicians, they have such an important role. Um, you know, and I really I applaud what Ben and his group are doing. They're going from we're good at filling out documents, we're good at having discussions and planning for the future with clients, but they're taking the next step. They're taking facilitator training courses to really learn more of the medicine piece and how to have these conversations and really gaining those skills to have these discussions. And kudos to them for doing that, not only from a legal perspective, but now from a facilitator perspective. I think this is where a really good partnership can come in. Our expertise as physicians, as clinicians, is really to talk about the medical aspects, to really talk to patients and families about disease processes and prognosis. And this is what it's like, heaven forbid, your heart stops, you stop breathing, and you die. This is what resuscitation really means. So we can have these discussions with patients and families from a medical perspective and kind of answer some of those questions. Where I think Ben and attorneys like him, where they're so beneficial, and this is where I want their help, is they can figure out and fill out the legal paperwork. They're so invaluable for powers of attorney for financial aspects, right? I'm not an expert on that piece. And I think this is really where the medicine folks and the attorney folks really can partner to really prepare and help folks out for the future from a medical perspective, from a legal perspective. Hey, you got to get your financial affairs in order as well. And have you thought about where your money may go and how do you prepare in the future? And boy, having some sort of long-term insurance and things like that might not be a bad idea. And keeping some money set aside for a facility and care can be helpful. So I really do see a really great partnership. It has been like that in the past and gets stronger over time.
Here's another one for you, Tim. How does one get a referral to you? What is the difference between palliative care and hospice?
Super. So getting a referral to palliative medicine. Well, let me back up for a second. Our ultimate hope, and I'm really proud of Theta Care because of the work we're doing. What I do as a specialist, as a palliative medicine specialist, is super important. But we can't see every single patient that comes into the hospital. We can't see every patient in the clinic. I wish we could go to everybody's home to have these conversations. That's why it's so important to train other folks how to do what we do, how to train folks how to use words, because words really do matter. So part of what we're trying to do at Theta Care is to train primary care docs how to have these conversations, to train emergency department physicians and clinicians to bring up some of these topics ahead of time. So for a lot of this, that primary palliative care piece can be done by your primary care doc with training, your oncologist, the internal medicine doc, the hospitalist. If things get more complicated, if there's conflict within family, if there's conflict within the medical team because they don't know for sure what to do, that's where adding a palliative medicine physician or palliative medicine APC or nurse or social worker really can help out. That's where we can, really kind of have those conversations, take them in different directions. So to get a palliative medicine clinician involved, doc, nurse practitioner, social worker, if you're in the hospital, just ask for a consult. You can ask your attending, you can ask your primary care clinician or the hospitalist for a consult with palliative, just to kind of help with some of the decisions that need to be made. It's no different than getting a consult from cardiology, getting a consult from a stomach specialist. In the outpatient and home world, you can just ask for a consult. You can even contact us directly to say, hey, I'd like to set up an appointment at some point. Very similarly to what you would do with primary care. So you can do that all on your own and search out, a theta care palliative provider for that care. The difference between palliative and hospice is palliative providers provide a lot of hospice care, but we do more than just hospice care. Hospice care is really for folks that have a prognosis of about 6 months or less. So two clinicians say, boy, I think Mr. Smith, based on his lung cancer that spread to his brain, really may have 6 months to live or less based on the current situation. They qualify for hospice. And they qualify for a hospice benefit, which means this whole entire team that can see folks wherever they are. Hospice team can see folks in the home. They can see folks at a nursing facility. They can see folks at an assisted living facility. And the Medicare benefit pays for this team to come where you are. It's a fantastic service, strongly recommended, especially if you're thinking more comfort. And boy, I don't want to go back to the hospital again because I don't feel better at the hospital. Or I want to focus on comfort. I want to focus on time with my family and in the home. Boy, adding hospice can really help immensely. It can help with symptom management. It can help with planning for the future. It can help anticipate problems you may have from your cancer or your dementia or whatever that is. So that's where the hospice team really can be helpful. Palliative really comes in quite a bit upstream. Again, if there's some decisions that need to be made based on your heart failure, lung disease. If you have questions about code status, resuscitation, things like that, the palliative team really can step in and help with those type of cases. But we work really hand in hand with your oncologist, with your cardiologist, with your primary care doc. We don't take the place of anybody. We just work as a group, as a team, to do what's best for you.
Here, Tim, I'm glad you touched on that. One of our questions. We'll make this one our last question, and then we'll wrap it up. So thank you. And so if she wants to know if you could talk about DNRs and their use, as well as the effectiveness of CPR outside the hospital setting.
Wow, that's a good one.
Yeah, there we go. We got a good crowd.
So CPR. What a great question. So so CPR, for folks who don't know, we provide a cardiopulmonary resuscitation. So doing chest compression, shocking the heart, breathing for somebody. If a person's heart stops and they stop breathing, so someone that dies from a massive heart attack, from a massive stroke, something unsuspected like that. So if something like that happens where they die, that's when CPR is applied. And that's kind of what I'm going to refer to. If you're in the hospital, you're there for pneumonia, you're there for your heart failure, something like that, we will always have a discussion with you. And the discussion is something like this. Heaven forbid something happens unexpectedly, where your heart stops, you stop breathing, and you die, right? What we want to know as physicians and folks in the hospital is how aggressive we should get with you. And aggressive means if your heart stops and you die, they're going to call a code in the hospital. You're going to have 25 people rushing into the room. Then they're going to start doing chest compressions. They're going to shock your heart. They're going to stick a tube down your throat to breathe for you with the hope that we can bring you back from the dead. Have you thought about this in the past? Well, it kind of depends. How successful is it? Well, if you ask the general public, and from watching ER and all those TV shows, the public actually says, well, the success is about 70 to 80%. 80%, right? Well, it's based on all the TV shows where you thump on somebody's chest twice, they wake up and kiss somebody and get married or something like that, right? Honestly, in real life, if this happens in a hospital setting, for all comers, if you die in the hospital, the chance that you'll leave the hospital alive is only about 15%, 1-5, right? Very important for you to know. If you're in the intensive care unit and really sick with really low blood pressure and sick and having fevers from pneumonia or something like that, if your heart stopped and you died in the ICU, the chance we could bring you back from the dead and you leave the hospital alive is about 2%. Not really good odds. But that's why these discussions are really, really, really important, and to have them early so that it doesn't scare folks. If you're young and healthy, very unlikely it's going to happen, but there's still only about a 15% chance we can bring you back from the dead and you can leave. If you're in the ICU, if you're sick, different story. If we send somebody to a nursing home and the same thing happens there, where their heart stops, they stop breathing and die, it's only about 5% success rate. That we can bring them back from the dead, they come to the hospital, they do what they need to do, right? So success rate from CPR is quite low. It's not meant to scare folks. Folks just need to understand what this means and what it could mean not only for you as a patient, but also the family members. Usually what will happen is folks will say, I don't want to think about it. Yeah, just do everything, right? Well, then we as clinicians have to do everything, including resuscitation. If you are brought back successfully, but now are on a breathing machine and are unconscious, guess who has to make decisions for you? It's your family members, your loved ones, those folks. Do they know what you want? Do they know how long you'd want to be in a breathing machine if we can't bring you back so you're conscious again, right? So that's why it's super, super important to have these discussions early. Ask those tough medical questions from your doctors, from the hospitalist, whoever you're talking about. Hey, doc, I know I have bad lung disease. How do you think I do if my heart stopped and I died? Well, maybe not very well. I don't think we could get you off the machine. Oh, okay. Well, in that case, I don't want that stuff done. And I better tell my loved ones I don't want that stuff done. I don't want to be intubated. I don't want CPR. That's just too much. Let me go. If it's my time, it's my time. Talk to your family members so they know about it. Talk to your power of attorney so they know what your wishes are. And then get those documents done. Get that advance directive done. Make sure that they scan it at the hospital so they know what you want and don't want. There's actually bracelets you can wear at home. A community do not resuscitate bracelet that shares that with everybody. Hey, if I'm at Pick and Save and my heart stops and I die, got this bracelet on, you better not bring me back from the dead, because if you do, I'm going to haunt you, right? Have these discussions, as difficult as they are. Again, these can be some of the best gifts you provide for your family, letting them know what you want, what you don't want, what the limits of care are. Great question.
Awesome. Thank you so much, Tim. And I think that will wrap it up for us today. So if we could just give a little round of applause to Tim. Thank you for being here so much. And if anybody has missed either yesterday's recording with Ben Adams or first part of today's with Dr. Jessick, this is a recorded Zoom session. So it is on our YouTube page. This one will be on there tonight. Ben's was on there. Ben's is already on there. And then it'll also be on our website. So for more information on speakers like Ben and Tim, and then Kim Kinner tomorrow and Kimberly Paul on Thursday, you can go, and other events, monthly classes and more, you can go to our website at www.fbacpp.org and on Facebook at Let's Talk Fox Valley. And also be sure to check your email after this, as there will be a survey where you can give feedback on this event and also enter to win a $50 gift card to the Blue Moon Emporium in Appleton. So if you already did it yesterday, please do it again. And you can also enter a second and third and fourth time, as many times as you are here for the events. So please check those out. And once again, thank you so much, Dr. Jessick. We really appreciate you sharing and informing us and educating us today. So thank you so much, everybody, and have a great night. And hopefully see you tomorrow at 5 p.m.